Hello and welcome back to the liver class where we discuss all the conditions affecting the liver, and here we will talk about the acute liver failure. This is a severe type of condition affecting the liver with poor prognosis, and here we will explain it. So we will go over the definition, the causes, the pathophysiology, the diagnosis and the treatment of acute liver failure. You can always use the chapters in the video description to skip to other parts of this video. And let's start with the liver functions and how they are affected by the liver failure. So the liver is responsible for detoxification of different toxins and materials in the blood coming from the intestine. So all the blood that is going to the intestine is drained back into the liver through the portal vein. So this is here the portal vein. It drains all the blood that is coming from the intestine, and it would detoxify all the materials in that blood, and it will then give it back into the hepatic vein and into the inferior vena cava, where it goes back to the heart to be pumped again. Another function of the liver is to support metabolism through gluconeogenesis and glycogenolysis, and it also has relation with immunity, and it aids in digestion through bile, and it also synthesizes some of the proteins such as the albumin and the coagulation factors. So when the liver fails, you expect these functions to disappear. So the blood would be full of toxins coming from the intestine, coming from the bacteria in the intestine and the food that is digested, and you would expect the patient to have low glucose, and the immunity would be disturbed, the digestion would be disturbed, and you expect the albumin to be low and the coagulation factors to be low too. So acute liver failure should have all of these elements to be considered acute liver failure. It should be severe acute liver injury. There is hepatocyte necrosis and apoptosis. There is 70 to 80% of the liver is non-functioning anymore in acute liver injury, and that's why the liver functions would not be available anymore. The duration of the liver injury should be less than 26 weeks, which equals to 6 months. There must be an evidence of encephalopathy, such as decreased level of consciousness or change in behavior. So the patient would be confused, stuporous, or even sometimes in coma, and there might be change in behavior. And there is impairment of the synthetic function of the liver. There is abnormal coagulation profile. The INR is more than 1.5. And the patient should not have liver cirrhosis or pre-existing liver disease to be considered an acute liver failure. So we make sure that the duration is less than 6 months. There is evidence of encephalopathy. The coagulation profile is impaired, and the patient has no pre-existing liver conditions to be considered an acute liver failure. Now let's talk about the causes of acute liver failure. So when the patient is present with acute liver failure, think of liver diseases that causes a lot of damage in a short period of time. Examples of those are drug-induced hepatitis due to paracetamol ingestion. This is the first most common cause of liver injury. So when the patient present to you with acute liver failure, think of the paracetamol ingestion as number one, because it is the most common cause. Then the second most common cause is the viral hepatitis. So previously those were reversed. The viral hepatitis was number one and the drug-induced hepatitis was number two. But nowadays it's the drug-induced hepatitis to be number one and the viral hepatitis to be number two. Then you think of shocked liver due to ischemia or hypoxia, and you think of Budd-Chiari syndrome, which is hepatic vein thrombosis. There's a thrombus blocking the hepatic vein and the liver can't drain anymore, so it is congested. And you also think of the veno-occlusive disease and the mushroom ingestion. Mushroom is also toxic for the liver, so you think of that too. Wilson's disease, sepsis also may lead to acute liver failure, autoimmune hepatitis, acute fatty liver of pregnancy, and you also think of HELLP syndrome. The H is for hemolysis, then elevated liver enzymes, and then low platelets syndrome. This also causes liver failure, and heat stroke, and malignant infiltration by some type of cancer. It might also lead to acute liver failure. Slow progressive liver diseases don't cause acute liver failure, but rather cause chronic liver failure, like the non-alcoholic fatty liver disease, the hemochromatosis, the primary sclerosing cholangitis, the primary biliary cirrhosis, the alpha-1 antitrypsin deficiency, and also the alcoholic liver disease. Now, what is the pathophysiology behind acute liver failure? Well, most causes lead to hepatocyte ATP depletion, so there is no energy anymore. The cells start to swell, and the cell membrane disruption. So the cell membrane would rupture because of the swelling of the cells, and this would lead to massive hepatocyte necrosis and apoptosis, which lead to liver failure. The percentage of the necrotic hepatocytes would be about 70 to 80% of the liver for it to cause acute liver failure. Now let's talk about the signs and symptoms of the patient presenting with acute liver failure. So they present with fatigue, they present with weakness, confusion because of hepatic encephalopathy. So we talked about on how the intestine blood supply would be drained into the portal vein to be detoxified by the liver, and the blood will come back into the circulation. Well, when the liver is not functioning anymore, the toxins in the blood coming from the intestine would come and would pass the liver, and it would go directly into the circulation, and it would reach to the brain, where it would cause hepatic encephalopathy. And jaundice also occurs due to hyperbilirubinemia. So we all know that the bilirubin is metabolized by the liver, and once the liver is not functioning anymore, the bilirubin will stay in the circulation, and this would lead to hyperbilirubinemia. There is of course hepatomegaly, because the cells would swell and all the liver would swell, which lead to liver congestion. There is of course abdominal pain, especially the right upper quadrant part of the abdomen where the liver is located. And also there is abnormal liver function tests. There is elevated AST, ALT, and there is abnormal coagulation profile, the elevated PT and PTT, and this might lead to bleeding in the patient. And there might be thrombocytopenia due to the loss of the thrombopoietin. So the thrombopoietin is secreted by the liver to work on the bone marrow to stimulate it to produce platelets. And once the liver is injured and there is no thrombopoietin anymore, this would lead to thrombocytopenia because the platelets are low because of that. So while you take history from a patient with these symptoms, you focus on a number of points. So you take a comprehensive history and you ask for these points, the timeline of the symptoms and the progression of them. This will guide you into one of the diseases that cause the acute liver failure, and you ask them about any history of hepatic disease, and you ask about the drug history, looking for acetaminophen toxicity. You ask about the family history, looking for Wilson disease and thrombotic disorders, and you ask about any recent surgeries, looking for possible toxic medications used like some anesthetic agents during these surgeries. On examination, you focus on checking the vitals, looking for hypotension, and you also do abdominal examination. In the palpation, you look for the pain and tenderness in the right upper quadrant, and you do the special test for ascites like shifting dullness and fluid thrill. and you do mental state examination looking for any alteration in the mental state, and you check the temperature for fever looking for infections. Now let's talk about the diagnosis of acute liver failure. So there should be some requirements for us to diagnose the acute liver failure. Those include an evidence of liver injury, that is by doing a liver function test for the patient, and we find that there is elevation in the AST and ALT, and those are the liver enzymes. When the hepatocytes get injured, they release those enzymes. So when they are elevated, this means that there is a liver injury. There should be an evidence of hepatic encephalopathy, through that there is changes in the behavior of the patient, or there is decreased level of consciousness. And if the liver injury is severe, the patient might be in coma. And we do a coagulation profile looking for the INR. If it is more or equal to 1.5, this also is required for us to diagnose acute liver failure. And with all of those elements, the patient also should not have any previous liver disease or liver condition. And also the duration of these symptoms should be less than 26 weeks, which is about 6 months. And you also have to do a follow-up investigations in form of glucose test looking for hypoglycemia, and bilirubin test looking for hyperbilirubinemia. And you also do CBC looking for low platelet count. You do ultrasound to look for Budd-Chiari syndrome, which is thrombosis of the hepatic vein. And you do kidney function test looking for acute kidney injury in form of elevated urea and creatinine. And you do electrolytes looking for electrolyte abnormalities. And you do several abdominal imaging investigations, such as a CT scan looking for cirrhosis, features of portal hypertension, hepatocellular carcinoma, and vascular problems. Now, if you didn't identify the cause through these investigations mentioned before and through the history and examination, you can do a transjugular liver biopsy and examine the biopsy for any type of condition affecting the liver. Now let's talk about the management of acute liver failure. So you admit the patient to the intensive care unit, and if you already know the cause, then you treat the cause that you know about. And if you don't know the cause, then give an acetylcysteine, which is a paracetamol antidote. Remember, I told you in the beginning that paracetamol-induced liver failure is the most common cause of acute liver failure. So you give the patient directly an acetylcysteine if you don't know the cause, because you assume that the patient has paracetamol toxicity, and then you can look for the cause. And you treat the identified cause, and if the treatment not succeeded, then you do liver transplantation. Acute liver failure management is quite complicated, so there is a supportive management that you have to give to the patient, such as maintenance IV fluids, and you also control the acid-base balance, and you control the electrolytes. You monitor the patient for any bleeding. Remember that the patient have a coagulopathy. They can't make the coagulation factors, so they have a coagulopathy. They might bleed in any second, and once they are bleeding, you have to treat them with the blood products. And you also do blood and urine cultures, and start empirical antibiotics if the patient have fever. And you also do serological testing looking for any hepatitis antibodies or antigens. And you monitor the hepatic encephalopathy, and you protect the airway. So when the patient gets into coma, you have to protect their airway by intubating them and putting them on ventilator. And you provide nutrition for the patient. You monitor for hypoglycemia, and you maintain the blood glucose between 160 and 200. Remember, the patient glucose control is not good anymore, because the liver is responsible for gluconeogenesis and glycogenolysis, and once those are lost, the glucose would be low. There is hypoglycemia, and you have to supply the glucose to the patient. Finally, let's talk about the complications of acute liver failure. So there might be a renal failure with the liver failure and sepsis secondary to the infection. If the liver failure is caused by infection, there is hypoglycemia, as we mentioned before. There is cerebral edema. Most common cause of death in acute liver failure is the cerebral edema. Edema leads to intracranial hypertension, ischemic brain injury, and herniation. And the cerebral edema is triggered by hypoxia, hypotension, decreased cerebral perfusion, and increased ammonia levels, because all of these would injure the brain tissue, and the brain tissue would swell, and it would lead to an increased intracranial pressure. And with that, we reach the end of this video. Thank you guys for watching. Please make sure to like this video and subscribe. And if you want to support more, you can by subscribing to the Patreon, link provided in the description of this video. Thank you guys for watching, and peace.